Hi everyone, my name is Isaac Wu. I'm a neuroradiologist. This is a talk about anatomy. So let's focus on hypothalamus, pituitary axis, and part of the limbic system. I'd like to start with a case. And all the case example I'm going to use in this lecture, the patient has been fully de-identified to protect their privacy. Now, this is a patient, 35-year-old, comes in with seizure. On EEG, the seizure is localized to the left temporal lobe. So let's look at the representative images here. You have a three set of coronal MRI. You have stir, flare, and T1. Focusing on the left temporal lobe, I think some of you already noticed that the left hippocampus looks very different than the right hippocampus in that it is smaller, so more atrophic. And on flare, you can see the left hippocampus also looks brighter compared to the right. So this is an example of medial temporal sclerosis, and we'll come back to this as part of our anatomy talk. So let's start with a general overview of the brain. By the way, majority of the gross anatomy photo I use in this lecture comes from University of British Columbia Neuroanatomy Lab. What a fantastic resource with lots of great pictures and lectures. So I highly recommend you to go check it out for your future reference and study. Let's start with mid-sagittal view. There are lots of important midline structures that you can see very well in this perspective. Starting from the back, underneath the tentorium, you have a cerebellum. Anterior to that, you have a shadow of a hummingbird. That's a brainstem. You have midbrain, pons, medulla. The hummingbird's eating a small piece of berry. That's mammillary body, important component for hypothalamus and for the limbic system. Right in the middle, you have a large commissure fiber. Now, commissure fiber is the one that crosses left to right, so that's a corpus callosum. Contrast that to two other type of fiber, that's projection fiber that connected the superior part of the brain to inferior part of the brain or to the spinal cord, such as cortical spinal tract, or with association fiber that's connecting to the ipsilateral of the brain, same side to the brain to the same side of the brain. Underneath the corpus callosum, you have an arch-like structure, fornix, coming from the word arch. Fornix connect anteriorly to the mammillary body. It's another important part of the limbic loop. Above the corpus callosum, you have this bell-shaped gyrus, singular gyrus, also an important component for limbic system. Now let's look at the mid-sagittal view on this T1 weighted sequence. You can see the same structure just as well. You can see the cerebellum, the midbrain, pons, and medulla, and the small piece of berry, that's the mammillary body. So look like a shadow of a hummingbird eating a berry. You have the fornix that's connecting to the mammillary body. Anterior to the fornix, there's another commissure fiber that crosses the left to right side of the brain. That's the anterior commissure. Above the fornix, you have corpus callosum. That has a forepart, the hook-like part, rostrum, bending of the knee, genu, body, and the bulbous posterior part, the splenium. This is example one of the more common congenital anomaly. Notice that on the midline sagittal view, one of the important structures is missing. The corpus callosum is not there. If you look at the coronal view, you see this very characteristic upturn of the lateral ventricle and highlighting of the third ventricle. This is agenesis of corpus callosum. On the coronal view, you have this typical so-called Texas Longhorn sign, look like a Texas Longhorn. Other structure, the bell-shaped gyrus above the corpus callosum, the singular gyrus. Now, using the singular gyrus, you can find singular sulcus above. Notice that right at the margin of the singular sulcus, you have the marginal part or pars marginalis of the singular sulcus, also referred to as marginal sulcus. Using marginal sulcus, you can identify another important sulcus right anterior of that. That's the central sulcus. Using another prominent sulcus posteriorly, the parietal occipital sulcus. Now on the mid-sagittal view, you can separate frontal lobe from parietal lobe from occipital lobe. On MRI also, frontal lobe separated by central sulcus, parietal lobe, then occipital lobe. So now let us focus on or comb down on the center portion. Within this central area, you can see there's a lateral ventricle, third ventricle, and the fourth ventricle. The connection between lateral and third ventricle is through the foramen Monro or interventricular foramen of Monro that's going underneath the arch-like structure of the fornix. The third ventricle and fourth ventricle is connected by cerebral aqueduct. The roof of cerebral aqueduct is this tectum or the tectal plate or quadrigeminal plate. There are four nodules that on the mid-sagittal view I can use as my orientation. The first nodule, of course, is the memory body that we just showed you earlier, and that is connected to the fornix anteriorly and posteriorly. That's connected to the hippocampus, as I will show you in detail later. The memory body is also connected to the anterior thalamus via mammillothalamic tract, and it connects to the brainstem via mammallotegmental tract posteriorly. The memory body is important for recollective memory. So if there's a damage to this area, such as in the case of Wernicke's encephalitis, patient may suffer intraocular amnesia. It's also important for spatial memory. On this slightly tilted view, again, I like to show you the connection between the hippocampus that's hiding, that's partially dissected, as you can see, and it's connected via the fornix into the mammillary body, an important part of the limbic loop. So there's another nodule that's sitting right above the tectal plate, the pinecone-shaped nodule. That's a pineal gland. Now, pineal gland is important for secretion of melatonin. That is important for the function of circadian rhythm, the day and night cycle regulation. And on this mid-sagittal T1 weighted sequence, you can see the pineal gland very well sitting above the tectal plate. Now, pineal gland is also referred to as a third eye or pineal eye. Why? That's because in some creature, there's actually a photoreceptor that's still open. As you can see in this reptile, that has a direct connection into the pineal gland that stimulates the day and night cycle regulation. And because of this connection, the common lineage between the photoreceptor cell with the pineal side, in a case where you see in this example, a pediatric patient with bilateral intraocular lesion, you are looking at bilateral retinoblastoma. Whenever you see that, pay particular attention to the pineal region, because sometimes you will see a pineal mass, often pineoblastoma. In that case, that becomes the trilateral retinoblastoma. Also, because the delicate relationship between, or the proximity between the pineal gland, the tectal plate, and the cerebral aqueduct, it's not surprising that when you have a large pineal mass, often the first place that tend to obstruct is cerebral aqueduct. So patient will present with a symptom of obstructive hydrocephalus, such as in this case. Another important nodule that you can see right in the midline is the interthalamic adhesion. That's sitting between the thalamus. Remember, thalamus is that paired gray matter structure that's sitting above the midbrain that serves as an important relay station. It's symmetric left and right. In between, there's a connection. That's the interthalamic adhesion or massa intermedia, intermediate mass. Another nodule anterior to the fornix. That's the anterior commissure that connects left to right side of the brain. Now, if you have anterior commissure, you must have a posterior commissure, right? The posterior commissure is harder to identify on the mid-sagittal view, especially on MRI. So what you need to do is identify the pineal gland, find the inferior pineal stalk, then you can find your posterior commissure right in the middle. If you draw a straight line between the anterior commissure and posterior commissure on the mid-sagittal view, that is a nice orientation you want to use for your axial view. In other words, a properly done axial view, you should have the anterior commissure and the posterior commissure intersect each other on the same slice. Just like in this case, here you can also see part of the pineal gland. Right underneath the massa intermedia, you can see this shallow groove right there, the hypothalamic sulcus or hypothalamic groove. That is a boundary between thalamus above and hypothalamus below. The hypothalamus is connected to the pineal gland connected to the pituitary gland via the pituitary stalk. The pituitary gland, the so-called master gland. And this area right here is the limbic system. There are many subcomponents to the limbic system. Not everybody agrees what's included within the limbic system, but there are some key components that's listed on this list that we can see quite well on MRI, such as amygdala and the hippocampus. So with amygdala, that's an almond-shaped structure that's sitting anterior to the hippocampus. Its chief function is regulation of fear and threat response, as well as some positive stimuli and formation of emotional memory. Posterior to that, you have a structure that looks like a seahorse, or at least someone think it looked like seahorse. Now, I find this picture on Wikipedia. If you include the memory body, the fornix and the memory body with this dissection, it does kind of look like a seahorse. And the connection between the hippocampus through the fornix into the memory body is something that we already described earlier. And in this diagram, again, amygdala is anterior, followed by hippocampus, fornix, and anterior to the fornix is the anterior commissure, and finally the fornix connected with memory body. And if you follow that on MRI, you can also see that very well on this T1 sagittal view. And initially, you identified this gray matter structure that's hippocampus. Sitting right superior to that, you see this very thin, bright signal. That's a fimbria, part of the white matter tract. And follow this white matter tract posteriorly, follow my arrow. You can see that this tract is connected into this arch-like structure underneath the corpus callosum. That's fornix. And continue down, notice that the fornix is connected into the mammillary body. So let's look at the coronal view through the amygdala in the front and the hippocampus in the back. So the first slice is through the amygdala. You can see amygdala, and at the same level, roughly, you can see the anterior column of the fornix. And more posteriorly, there's a slice through the hippocampus, and as well as you can see the fornix body more posteriorly. Now, one of the questions is that on the coronal view, especially on MRI, how can you tell you're looking at the amygdala or you're looking at the hippocampus? I think one way to identify that is utilize the ventricle. So for amygdala, you will see that the ventricle is sitting below the amygdala. On the other hand, with hippocampus, the ventricle is sitting on top of the hippocampus. That's one quick way you can identify what's what. And let's look closer, look at the slice through the hippocampus. And there are other structures adjacent to the hippocampus. So the next gyrus next to the hippocampus is the parahippocampal gyrus. Adjacent that, you have a collateral sulcus, and that separates the parahippocampal gyrus from the adjacent fusiform gyrus. And then more laterally, you have an inferior, middle, and superior temporal gyrus. On this slightly tilted mid-sagittal view, you can see the bell-shaped singular gyrus sitting above the corpus callosum. Notice that posteriorly, there's a thin section of the singular gyrus that is the isthmus of singular gyrus that in turn extending into the parahippocampal gyrus. In the medial portion of the parahippocampal gyrus, you see this bulbous dilatation or swelling of the medial aspect of the parahippocampal gyrus. That is the ungus. So let's look at this T2 coronal view. Let's identify the hippocampus and the amygdala. And one of the things that helped me remember is my favorite dessert, almond flow and seahorse. Now with almond flow, so I think of almond, amygdala is flow above the water. So the ventricle, I look for CSF. If the structure is above the CSF or the ventricle, that's amygdala. On the other hand, I think about seahorse, hippocampus, that's living under the sea. So it should be under the water, under the CSF. So I use ventricle to help me identify these structures. Other structures that we mentioned earlier, you can see adjacent to the hippocampus, you have parahippocampal gyrus. The next sulcus is the collateral sulcus. That separates the parahippocampal gyrus from the fusiform gyrus. Next to that, you have inferior, middle, and superior temporal gyrus. So let's take a closer look on the hippocampus itself. on the coronal T2 weighted sequence, that is a view that we use to look for hippocampus. On this corresponding histology, you can see that hippocampus comprises of four regions. That's CA1, CA2, CA3, and CA4. CA stands for cornu ammonis, because some people think that look like horn of Ammon. So cornu ammonis. That's a hippocampus proper. Medial to that or underneath that, you have another C-shaped structure that is dentate gyrus. Together on MRI, you can see that look like interlocking C, and that is the internal architecture that you're looking for when you do an inspection. Next to that, you have a region called subugulum, sort of a transitional zone. Together, all this structure forms hippocampal formation. Next to that, you have entorhinal cortex and perirhinal cortex. That together forms parahippocampal gyrus, as you can see also that on the MRI. The next sulcus is collateral sulcus that separates the parahippocampal gyrus from the adjacent fusiform gyrus. Next to the fusiform gyrus, you have inferior, middle, and superior temporal gyrus. The hippocampus function is best known for memory and learning formation, and it is forming the recent memory, and it also serves to consolidate the short-term memory from long-term memory, and it's also important for spatial navigation. There are several pathways for output of information. For example, one of such pathways is from the hippocampus through the subugulum, going out into the parahippocampal gyrus, then to the cingulate gyrus and into medial frontal cortex. Another one is the one that we showed earlier. That's through the fornix, extend to the memory body, which in turn extend into the anterior thalamic nuclei, then to the subtal area. However, as you can see, even under 3T Tesla, the hippocampal anatomy is not as detailedly seen as you can with the histologic slide. However, that may be changing because 7 Tesla is coming. This is an example that I took from literature coming from USC. As you can see, the internal architecture now can be much better seen. So it's possible that we now have to describe that specifically which region of the hippocampus or hippocampal formation is affected by pathology. This is an example that under 3T that I showed you earlier. This patient, remember, has a left mesotemporal sclerosis. The flare is brighter on the left side compared to the right side and is more atrophic. So in order to diagnose this hippocampal sclerosis, you want to see three things, at least 2 out of 3 things. Number 1, atrophy of the hippocampus, check. Number 2, loss of internal architecture, that interlocking C is missing, check. And in this case, you also see asymmetric abnormal signal. Flare is brighter on the left side, check. So this is a classic case of mesotemporal sclerosis. Remember the loop between the hippocampus, fornix, and the memory body? Therefore, some of the secondary signs that you may see with mesotemporal sclerosis can be ipsilateral atrophy of the fornix, as in this case, and ipsilateral atrophy of the memory body, as you can see on this case. To identify the hypothalamus, again, you find the thalamus and find that shallow hypothalamic sulcus. That serves as the superior boundary of the hypothalamus, and the hypothalamus is roughly this triangular area that's on each side of the third ventricle. This is a beautiful picture from British Columbia in the Eastern region. First of all, again, look for those 4 nodule index space, the memory body, anterior commissure, massa intermedia, and the pineal gland. And you can see that equally well on MRI. So the anterior boundary of the hypothalamus, or the anterior wall of the third ventricle, also is this thin structure that's connected between the anterior commissure as well as the optic chiasm. That's the lamina terminalis. So you can see that also barely on the MRI. And that is optic chiasm. And then you can see this little indentation, that's the infundibulum. And infundibulum leading into infundibular stalk or pituitary stalk, of course, that's connecting to the pituitary gland. And here it's missing, so I just fill in with a shadow. And you can see that mammary body on MRI, infundibular stalk that extended into the pituitary gland. You can see a small divot or recess above the optic chiasm, that's supraoptic recess, or also go by optic as well as chiasmatic recess, and another small divot that's an infundibular recess sitting on the infundibulum. And again, you can see that also fairly well on a sagittal T1 weighted sequence right there. If you draw a line between the mammary body to the optic chiasm, that straight floor, that is tubus cinereum. A classic board exam question would be something look like this. This is an 18-year-old patient comes in with gelastic seizure or laughing seizure. Did you spot the pathology? You can see that a line should be straight. The tubus cinereum should be straight without any nodule. So right anterior to this particular case, right anterior to the mammary body, you see extra nodule. That is tubus cinereum hamartoma. The classic symptom patient will present is gelastic seizure. The hypothalamus is roughly outlined here. The posterior extending close to the pineal gland. And the mammary body is considered part of the hypothalamus. And of course, on the mid-sagittal view, you will not see it because you are seeing the third ventricle. They are lateral to on the lateral wall of the third ventricle. And the connection between the hypothalamus, remember you have hippocampus more posteriorly, and that extending into the fornix, and fornix in turn connected with mammary body. The mammary body sends through the mammillothalamic tract into the anterior thalamic nuclei, and that in turn has a connection extending into the cingulate gyrus, and cingulate gyrus loop back into the parahippocampal gyrus, and then extend into entorhinal cortex as part of the information input and output. And those complete a circuit, the classic Pape's circuit. So let's take a look at the relationship between hypothalamus and the pituitary axis. If you look at this busy diagram from the article Miller's, you can see that there's a complex interplay between various hypothalamic nuclei and the anterior and the posterior pituitary gland. On this histologic section, you can see the anterior pituitary gland and the posterior pituitary gland and pituitary stalk, they look differently. And turns out on imaging, on MRI, they also look differently, that you can distinguish anterior pituitary gland from posterior pituitary gland. Developmentally, the anterior and posterior pituitary gland forms differently. For the posterior pituitary gland, it starts with the floor of the diencephalon coming from the neuroectoderm, whereas the anterior pituitary gland is coming from the oral ectoderm, the stomodium. So at some point in time, they start to form this small pouch, whereas the posterior part or the superior part forms the infundibular recess that will form the future neuroectoderm. And you can also see this outpouching develop the Rathke's pouch that will extend. They will start to go down and meet in the middle. The Blake's pouch will break off and eventually wrap around the pituitary stalk, and that forms the future anterior pituitary gland. So that would be the anal hypophysis, and the posterior pituitary gland that remains a connection to the diencephalon. That's neural hypophysis. And on MRI, the T1 weighted sequence, the anterior pituitary gland clearly looks different than the posterior pituitary gland. And on T1 weighted image, the neural hypophysis, the posterior pituitary gland, is literally referred to as the posterior T1 pituitary bright spot. Here you can also see the infundibular stalk quite well, and anterior to that you have the optic chiasm. So some of the issues that you can run into developmentally is a case like this. This is an example of a 9-year-old boy with growth hormone deficiency. Here, if you're looking for the posterior T1 pituitary bright spot, you do not see it in the expected location. Instead, it's up there, it failed to migrate. So that is the ectopic posterior pituitary gland. On this drawing from Radiopedia, you can see that the anterior pituitary gland and the posterior pituitary gland has different subcomponents. But on imaging, we can pretty much just see the anterior pituitary gland, posterior pituitary gland, and the infundibular stalk. And the anterior pituitary gland, posterior pituitary gland, they also function quite differently in terms of hormone production and storage. The anterior pituitary gland has its own portal system. Now, the anterior pituitary gland, as you remember, secretes various different hormones. And initially, the hypothalamus would produce various R hormones, releasing hormones, such as TRH, CRH, PRH, etc. So the hormone will in turn stimulate the production of the other hormones within the anterior pituitary gland. So the anal hypophysis produces its own hormones. So you have secretion of the releasing hormone that extended into the nuclei within the anterior pituitary gland, and that in turn will secrete hormone downstream into the system, such as TSH, adrenal gland, and growth hormone, etc., etc. The posterior pituitary gland functions differently, though, in that the posterior pituitary gland does not produce its own hormone. Rather, it serves as a storage. So there are two main hormones that's contrast to the anterior pituitary gland, where you have lots of hormone production. Here, you have only two type of hormone for storage. That's oxytocin and ADH. So that it's produced in the hypothalamus and then stored within the posterior pituitary gland. Perhaps that's why it looks bright on T1. And that's posterior T1 pituitary bright spot. And absence of the posterior T1 pituitary bright spot is something that I would make a comment on. And sometimes it could be pathologic. For example, in this case of 6-year-old with diabetes insipidus, here you can see the expected posterior T1 pituitary bright spot is absent. So what does this patient have? That means that they have a problem with vasopressin or ADH production. So patient has an antidiuretic hormone deficiency, and therefore patient present with symptom of diabetes insipidus. Now, this is an example of a young, healthy patient. You can see before contrast is given, you can separate the anterior pituitary gland from the posterior T1 bright spot, the neural hypophysis. After contrast, though, the entire pituitary gland as well as infundibular stalk should line up homogeneously without a focal lesion. So that's anterior pituitary gland, posterior pituitary gland, stalk, and optic chiasm. On coronal image, you can also see again the pituitary gland should enhance homogeneously, and pituitary stalk should be right at the midline, extending into the infundibular, just anterior to the optic chiasm. So some of the potential lesion that can come across fairly commonly in adult is a case like this. Somebody presents headache and usually vision problem. And here you can see on T1 and T1 post-contrast, clearly you have expansion of the bony cella. There is a large mass lesion that's expanding the cella as well as with supracellular extension. On T2 weighted image, you can see that there's expansion cause elevation of the optic chiasm. Therefore, patient present with visual issue. And here again, post-contrast, you can see that the optic chiasm is markedly compressed and elevated, and compare that to a normal patient where the infundibulum should be nice, thin, and midline, and the optic chiasm should not be compressed. So this is a case of a pituitary macroadenoma. That's all for this talk. I hope that was helpful. Thanks for your attention.